Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, A Personalized Approach to Pediatric Asthma Management. Today's program is supported in part by the Pediatric Pulmonary Center at UAB. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses expiring on May 31st, 2018, and 2 years for social workers expiring on May 31st, 2019. I'm Claire Lenker, Associate Professor of Pediatrics at the Pediatric Pulmonary Center at UAB, and I would like to introduce our faculty presenter today. Dr. Isabel Varela-Lowell is the Associate Professor of Pediatric Pulmonology and Director of the Pulmonary Care Unit at Children's of Alabama. Welcome and thank you for being here.
Good afternoon. Thank you for joining us in this discussion of asthma and asthma management. Today I'm going to review briefly the definition of asthma and give you an overview of how asthma presents and the triggers for asthma, go over some of the epidemiology of asthma, and then focus really on asthma management, how we assess management and how when children are not well controlled, we can take steps to improve control in a personalized fashion. So asthma is a chronic inflammatory disorder of the small airways associated with airway hyperresponsiveness and obstruction. It leads to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Asthma occurs in the very small distal airways, and an asthmatic airway has swelling in the lumen or the wall of the airway at all times. When an asthmatic has an exacerbation, that wall becomes more swollen, mucus starts to accumulate, and the smooth muscle that wraps around those bronchioles starts to tighten. Combination of those things causes for reduced airflow through those bronchi, air trapping in the alveoli, and that manifests as wheezing and coughing and shortness of breath. Typically, an asthmatic will present with this sort of history. They've had recurrent episodes of wheezing or cough, can have some troublesome cough at night that can sometimes wake them up. They will cough or wheeze after exercise. They can cough or wheeze or have some chest tightness after they're exposed to airborne allergens or pollutants. And they tend to have colds that go to the chest or take more than 10 days to clear. It's not uncommon for us to see asthmatics in clinic who will have a cold that lasts for 2-3 weeks, be well for 2 or 3 weeks, and then have another cold that lasts for 2 or 3 weeks. And when questioned, it's not the runny nose, the fever, all of that that's persisting. It's that cough that's lasting. And that's very characteristic of asthma. There are multiple things that trigger asthma. There can be inflammatory factors, things like respiratory infections, exposure to allergens, exposure to work chemicals or materials, irritants such as a change in the temperature, cold air, warm air, exercise, stress and emotions. Even good emotions, laughing can trigger an asthma attack in some. And then strong odors, perfumes, cleaners, paint, solvents, all of those things can trigger asthmatics. And then there's some others. Medications such as NSAIDs can cause asthma attacks, food additives, pollutants. Exposure to tobacco smoke is a big factor. And then in some, gastroesophageal reflux can exacerbate or trigger some asthma. As of 2015, 8.4% of children in the U.S. had asthma, and 7.6% adults. If you take both children and adults, there's a higher female predominance, and it definitely is something that is more common in the African American community. If you break down that data and just look at children, you will see that most of our asthmatics are diagnosed in the elementary school years, and after that the numbers remain fairly consistent until young adulthood, where they start to drop. I'm not sure that that's a drop in incidence of asthma or a drop in recognition of the fact that they still have asthma. Unlike the overall population, in children, asthma is more common in boys than in girls. And it's particularly common in African Americans and Puerto Ricans. And there are a large number of asthmatics who live below the federal poverty threshold, making it difficult for them to access care, to get medications, and to even maintain the sort of environment that would protect their children from having asthma exacerbations. In 1997, the National Heart, Lung, Blood Institute came out with guidelines for the diagnosis, classification, and treatment of asthma. This is just one of the many charts in their document for classification of asthma severity for 5 to 11 years of age. And it's really just to demonstrate that there are first two types of asthma, intermittent asthma and persistent asthma, and that we grade the severity of asthma based on as much daily symptoms as we do on number of exacerbations and illnesses and steroid use. So children who are having daily symptoms or frequent symptoms chronically tend to be more in the moderate and severe category. Intermittent asthmatics, by definition, should have one or less attacks a year. Anyone with more than that is a chronic asthmatic. And the difference being that intermittent asthmatics we treat with albuterol as needed, and all other asthmatics need some sort of daily preventative medication to help keep their asthma under control and prevent exacerbations. So for each of the classifications, the National Heart, Lung, Blood Institute gave recommendations for treatment. And those recommendations are in step 1, 2, 3, and 4. Step 1, again, is for intermittent asthmatics, and it's just a bronchodilator when they need it. And if their exacerbation is particularly bad, they may need some glucocorticosteroids orally. Step 2 is for our mild persistent asthmatics, and usually a low-dose inhaled corticosteroid is the preferred treatment there, but you can also use a leukotriene modifier. Moderate and severe asthmatics may fall into step 3, 4, 5, depending on how well they're controlled or not. But at that point, we usually start using combination inhaled corticosteroid, long-acting beta agonist medications, or adding to an inhaled corticosteroid a second agent like theophylline or leukotriene modifier. If the patient is sick enough and is not responding to treatment, we keep on increasing the doses. If on high dose you're not managed, then we consider oral glucocorticosteroids at the lowest dose possible chronically. Or we can think about anti-IgE or anti-IL-5 treatments. The anti-IL-5 was added to this chart because it wasn't even available in 1997. It is a rather newer treatment, but it is something that's offered at most allergy offices and pulmonology offices. It's important to remember that asthma can be effectively controlled in most patients by intervening to suppress and reverse that inflammation and treat the bronchoconstriction and the related symptoms. Asthmatics do not have to cough all the time. They do not have to be symptomatic all the time. And unfortunately, there's still that expectation amongst some families that my child has asthma, so they're always going to cough. They're always going to have trouble running. They're always going to have trouble with this. And that is not the case. And we need to emphasize that when we talk to patients and families. So in this cartoon, this gentleman says he stopped to smell the flowers and now where's his inhaler? We cannot underestimate how important controlling triggers is in asthma care. I can have you on the best medication. If your triggers are not controlled, you will not be well controlled. And allergens are a huge trigger in asthma. So early intervention to stop exposure to the risk factors that sensitize the airway will help improve the control of asthma and reduce the amount of medications that are needed. It's very important to help patients and families identify what their triggers are. When we treat asthma, we have several goals in mind. We want to achieve and maintain control of symptoms, not just exacerbations, but those daily, weekly symptoms. We want them to have a good quality of life, to have normal lives, to not be limited in their activity or restricted from going to work or to school or enjoying themselves playing with their friends, whatever it is they want to do. So again, maintaining normal activity levels, including exercise. There are still many parents who come and ask for excuses to keep their children out of PE. Asthmatics should be participating in PE. If your asthma is not well managed enough to do that, then it is a job of your primary caregiver or your pediatrician or family doctor or nurse practitioner to adjust the medications or to review why you're not well managed and help you fix that. But there are Olympic and professional athletes with asthma. Asthma should not be the reason you don't exercise. We want to maintain pulmonary function as close to normal as possible, prevent exacerbations, avoid adverse effects from asthma medications. We have to know what those are and be on the lookout for them. And we also have to do a good job of educating parents on what those might be. And then prevent asthma mortality. There are not many patients that die from asthma every year, but there's still more than should. And asthma mortality is still a very real problem. So how do we how do we measure asthma control? You can ask a patient about their daytime symptoms. Are you coughing? Are you having trouble with exercise? You can ask about how many times they wake up in the middle of the night coughing. How often are they using their quick relief inhaler, their albuterol or nebulizer? There are self-reports of control, like the asthma control test that patients can fill out that will kind of address some of these questions and give you a score to assess. You can find out about how many days of school they've missed or how many missed days of work they have, what their functional status is. Are they so limited by their asthma that they really aren't getting to school, aren't getting to work, aren't able to enjoy the things and do the things that they would like to do? Query about the utilization of their healthcare resources, how often they're seeing their doctors, they're going to the emergency room, going to urgent care centers for their asthma. And then you can measure inflammation using exhaled nitric oxide. That's not widely available in most practices, but it is in some, and that's another, perhaps more objective measure. So I wanted to kind of briefly go over the asthma control test. There are two versions of this, one for younger kids, which is completed by the children and their parent, and then the one for 12 and up, which is filled out by just that child. This is the older version. And basically, this is a validated questionnaire that has been studied and reliably predicts asthma control in patients. And it asks about symptoms in the last 4 weeks of time. Things like shortness of breath, how often their asthma interfered with their life, if they're able to sleep at night, how often they're using their rescue inhaler, and how they would rate their asthma control. The test is scored. A score of 20 or over is good asthma control. A score of 19 or lower indicates poor asthma control. This should not be the only tool you use to assess control. Some patients have difficulty with the questions. Some patients, you will get a different answer when you ask them versus what they answer on the sheet. So you should also follow up with a verbal dialogue about this test and what their scores were. But it is a very useful tool, and it kind of helps reinforce to parents and patients how we define asthma control. When they read these questions, they know these are the things that we are worried about, and these are the things that we are trying to control. Unfortunately, despite having a lot of good meds, guidelines on diagnosis, on classification, on treatment, and ways of assessing management, many of our patients are still failing to meet the goals of asthma therapy. In one study, 30% of the asthmatics under 16 were, and this was 2,500 patients, 30% were still having sleep disruptions more than once a week. 32% have missed work or school in the past year because of their asthma. 48% had limited sports participation, and 23% had unscheduled ER visits due to their asthma. So we need to be doing a lot better. Additionally, 2015 data shows us that of our children with asthma, 47.5% had one or more asthma attacks in the past year. And when we look at discharges, 18.3 per 10,000 are admitted for asthma annually. And most of those patients are, again, African Americans who may not have the same access to resources or to care. In terms of mortality, the national asthma mortality rate in children is 3 per million. In Alabama, we don't have childhood data. We have combined adult and children data, and it's 9.8 per million, which is actually somewhere in the middle. So the state mortality rates range from 7.4 to 13.1, with the average of being 10.3. So we're a little below average, but still that's much more mortality. That's 52 deaths in 2014 in Alabama alone because of asthma. So how do we optimize asthma management? How do we make this better? How do we talk to our patients and adjust their medications so that we get better results? The previous chart from the NHLBI was on how to classify asthma using symptoms. This chart here is more about how we're assessing control. So on controller medications, are they still having daytime symptoms? Are they still limited in their activities? Are they waking up at night or needing to use their beta agonists? What is their lung function? If they're having symptoms twice or less per week and not having any exercise problems or nocturnal awakenings, they're pretty well controlled. However, if they have any of those things, if they have any exercise limitation or any nocturnal awakenings or having daytime symptoms 3 or 4 times a week, they are considered poorly controlled. They are completely uncontrolled if they have 3 or more of the features in the partly controlled category. So why are patients uncontrolled? What's going on that we are not being able to better manage asthma? There are several factors. The first I want to talk about is ineffective delivery of treatment, poor technique. Asthma inhalers, HFAs, have to be given with spacers. There are many patients who don't use spacers, who don't know how to use spacers, or have not really received instruction on the use of an HFA. It is not intuitive. You don't just spray it into the back of your throat and it works. So technique is something that needs to be taught and reviewed regularly. Poor adherence is a huge issue. As with any chronic illness, it is hard to remember to take your medicines every day. And asthma patients are no better at that than anyone else. So this is something that we need to look at with every visit when a patient is not well controlled, and assess and try to address. Inadequate treatment. Maybe they're just not on the right medication or not on the right dose. Ongoing exposure to triggers. If, for instance, you have terrible allergies, or there is mold in your home or in your school, it doesn't matter what medications I have you on, your asthma will not be completely controlled because you're constantly being exposed to something that is triggering your asthma. Comorbidities, so allergic rhinitis, gastroesophageal reflux, there are a number of things, sinusitis, that can trigger your asthma and make it difficult to control. And we need to ask about those things and address those things when a patient is not well controlled. Severe therapy-resistant disease. This is almost a diagnosis of exclusion. You really need to make sure that the technique is good, that the adherence is good, that you're on the right treatments, that there's no triggers or comorbidities before deciding a patient just has severe therapy-resistant disease. There are very few patients that actually have therapy-resistant disease. This is an incredibly small number, but it does happen. And then misdiagnosis, maybe it's just not asthma. So I wanted to review 3 case studies to kind of go over how I approach asthma management and try to personalize it to my patients. First study is a 10-year-old Caucasian male with moderate persistent asthma. He's in a low-dose inhaled steroid and a long-acting beta-agonist, so a combination medicine. He's had 2 asthma exacerbations in the last 4 months requiring increased albuterol use and a steroid burst. At baseline, he's coughing 3 to 4 nights a week, and it occasionally wakes him up. They can't tell you exactly how many nights it's waking him up, but it is. And he has frequent exercise-induced cough and chest tightness and shortness of breath. He's also using his albuterol 5 times a week and has missed 5 days of school recently due to asthma. So when using this chart, this is obviously a patient that is completely uncontrolled. They're having daytime symptoms more than twice a week. They're having limitation of activities, nocturnal awakings, and frequent reliever use. So in assessing this patient, I would say that he had a moderate persistent asthma that is poorly controlled. And in trying to figure that out, these are the things I would consider. Does the patient have poor inhaler technique? Is he non-adherent? Is this the right medicine? He's on a low-dose medicine. Maybe he needs an adjustment up. Is there ongoing exposure to triggers? Is he in a house with cigarette smokers when tobacco smoke is one of his triggers? Is there a cat in the home when he's allergic to cats? Is there mold in the school? Those sort of things. And then comorbidities. Is he potentially having some reflux symptoms or has uncontrolled allergic rhinitis that is causing some of his problems getting his asthma under control? And then you investigate further. You develop that differential and you kind of go from there. So what we do at UAB is every visit we check technique. We teach technique when we first meet patients in their new visits, and then subsequently, every time they come to clinic, we ask them to demonstrate their technique, and we make corrections when needed. It is not sufficient to teach technique once. Often, they will come back even after they've been taught 2 or 3 times, still making some mistakes. And the technique is critical. Having good technique is what's going to ensure you get medicine into your lungs. I ask about missed doses. And when I ask this question, I try to normalize non-adherence. I stress that it's normal for people to forget medicines. We have very busy lives. There are a lot of things going on, and sometimes you're just trying to rush out the door and get to school bus on time and not be late, and that it's a very normal thing to forget. I don't ask them if they forget or if they're missing doses. I ask them how many times they're missing doses. It really doesn't matter what the number is if they give you a number other than 0. So it doesn't matter if they tell you I'm missing twice a week or missing 5 times a week. Either offers you the opportunity to talk about obstacles to adherence and strategies for improving adherence. So if they admit to missing doses, why? What's happening? Are you doing a better job remembering in the evening and not in the daytime, or vice versa? Is life just hectic? Is no one around to supervise the doses and supervise the child and make sure the child is getting medicine twice a day or however many times they're supposed to be taking it? What are the obstacles? If you suspect someone is not being adherent and they're not forthcoming with not being adherent, you can always check a refill history. I don't usually confront patients with refill histories. I haven't found that that's a very effective way to deal with that. I just then have the same conversation I would as if they had admitted it to me. Start talking about strategies for remembering. I review their triggers. Is there a continuous trigger that we haven't addressed and we need to address? And some are easier to address than others. Dust mite allergies, when you have carpet in your home, might be difficult for most families. We do the best we can. And then comorbidities. I ask about evidence of infection or allergies or gastroesophageal reflux and make sure none of that is coming into play. So in this 10-year-old, we evaluated his adherence. He's taking his medicine. It says he's taking his medicine. We don't have a strong suspicion that he's not. That I'll tell you later that doctors are not particularly good at predicting who's not taking their medicine. There's no triggers that he's continuously exposed to. There are no comorbidities. But his technique is poor. He's not using a spacer. And unfortunately, poor technique is a very common problem. In a study of 175 Latino youth in Chicago with asthma that were seen in the ED, only 27% had spacers. 75% of them had a quick relief medicine. Only 49% had a controller medication. Yet here they were being seen in the emergency room with an asthma exacerbation. And only one was able to demonstrate 100% of the inhaler steps accurately. The steps that were most often performed incorrectly or forgotten were just shaking the canister before dose administration, exhaling before they used the medication, waiting between puffs. You're supposed to wait 30 seconds to a minute between puffs, and inhaling correctly, especially with a spacer and a mouthpiece. It has to be a controlled, slow inhale with a breath hold. However, there were some 30%, 31% who didn't even actuate the med. They didn't even push down on the canister to release the medicine. 8 didn't even remove the cap. And 34% just didn't inhale. So technique is critical. An asthma medicine in the hands of someone who doesn't know how to use it correctly is worthless. So the medicine doesn't work if it's not getting to the lungs. It's that simple. And poor technique is a very common reason asthmatics continue to wheeze on good medications. Technique must be taught, checked, and reviewed in clinic. It is not sufficient to teach it once. And if you are treating asthmatics and prescribing inhalers, there should be someone in your practice who is able to do this. It's also important to remember that not every child can use or wants to use every device. Teenagers in particular don't like spacers. There are devices that don't require spacers. At the same time, younger kids really can't use dry powder inhalers correctly. They just can't generate enough force with their inhale. So there are age-appropriate medicines, And there are medicines that use spacers, don't use spacers, and kind of trying to get a feel for what your patient's preferences are and what they can do is important in determining medication. I'm not going to go into a detailed review of how to, or correct technique, or how to teach correct technique, because that would take a very long time. But I have listed a couple of websites here, including ours at the Asthma Team's Education Resources site, that have very good information and even handouts on correct technique and how to teach it and assess it. It is important that you not only provide verbal instruction, but that you provide written instruction. So teach in as many ways possible. People learn differently. Have them demonstrate technique, and then you demonstrate if they're getting it wrong, and then have them repeat it. Ask questions and encourage questions. Have them repeat back to you. Have them explain to you what they're supposed to do. And then repeat. We give patients a lot of information at every visit, and it is unrealistic to expect that they're going to remember everything. So repetition is key in everything we do. Just briefly, in children under 8, we tend to use a spacer with a face mask with all HFAs. These are the instructions. Again, I'm not going to go over them in detail, but essentially the mask has to fit their face. The child needs to take 6 normal breaths while the mask is on, wait for a minute, and then repeat the dose. And these instructions can be found on our website. 8 or over, or sometimes a very smart, savvy 6 or 7-year-old even, we use a spacer without a mask. The advantage of using a spacer without a mask is they will get more medicine. But until they're ready and until they can do it correctly, it is not appropriate to switch them. And you really have to assess and check. And again, the difference here is they actively inhale, they hold their breath for 10 seconds. So it requires that kind of cooperation and understanding. If you don't like using spacers, there are a number of dry powder inhalers available. And then there is actually even one that's not a dry powder that comes with a built-in spacer, so you don't have to carry an extra one, and that's the Aerospan at the bottom of the screen. And these are great options for those who really object to using spacers, especially our teenage population who don't like to carry around these big, bulky things. So on to case 2. This is a 4-year-old ex-preemie with a history of moderate persistent asthma with 2 previous hospitalizations. He's now in daycare and his symptoms have worsened, and we get this all the time. He wakes up 1 or 2 nights a week with a cough, and he coughs and gets short of breath with exertion when he becomes very active. He's using his albuterol 1 to 2 times a week and is on inhaled corticosteroids via a nebulizer twice daily. Has a lot of rhinorrhea, itchy eyes, and congestion. So again, in assessing control, he is in that poorly controlled, but not completely uncontrolled area. But still, there's room for improvement and room for adjustment in meds. So again, what kind of things to think about in an uncontrolled asthmatic? Again, inhaler technique, check it. Adherence. Is he on the right medication? Ongoing exposure to triggers or comorbidities. This child has allergy symptoms. So at the very least, those need to be addressed. But in this case, it was not just the allergy symptoms, but adherence that was an issue. Adherence is a big issue for asthma as a whole. Study in New Zealand of 101 children who presented the emergency room with asthma. They put electronic monitors on their inhalers to see how often they were using their medicine. Median preventer adherence was 30%. We know from other studies that inhaled corticosteroid use in chronic asthmatics is poor. Less than 50% of adults and adolescents, or adolescents and adults use them less than 50% of the time. Younger children, 49 to 73% of the time. We know from some refill history data that on average an asthmatic will refill their medicines 3 times a year. These are medicines that last a month. And physicians are very poor about predicting adherence. We only get it right a little less than half of the time. So some patients can weave a very good story and you think they're taking the medicine, and others you really feel like maybe they're not because you're not really well controlled, and surprisingly they really are. So we're not always right. And if there's a question, a refill history is usually helpful. The World Health Organization has said that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than improvement in medical treatments. We have good medical treatments. We need to ensure that they're being taken. And doing that will go a long way to improving the health of our asthmatics. So what are the factors involved in non-adherence? Well, there's non-medication and medication factors. We'll start with the non-medication. Parents and children and patients sometimes misunderstand what they're supposed to do with these medicines, how they're supposed to use them. Or they haven't really received good education on why they should even use them. They've just been prescribed without much explanation on how the medicine works, what it's supposed to do, what you can expect from that. So they'll have inappropriate expectations of the medicine. They'll think that maybe their QVAR is supposed to stop their asthma attack or their inhaled corticosteroid, or maybe that if they use their beta agonist 2 or 3 times a day, that will prevent their asthma. They have very significant misunderstanding of what these medicines do and how they're supposed to work. Some underestimate the severity of their disease. I have heard it's just asthma. And some people don't really recognize that asthma does lead to mortality. People die from asthma. People get admitted to the ICUs and intubated and put on heart-lung bypass. All sorts of terrible things can happen with an asthma exacerbation if it's severe. And it's not only severe asthmatics that have severe attacks. Mild asthmatics can have very severe attacks. So re-emphasizing that, teaching about that is critical. Attitudes towards ill health. Some people just don't want to be sick. They don't want to accept that they're sick. They don't want to accept that there's a problem. There are cultural factors. Different groups have different approaches to medicine, different opinions about, or different levels of trust of healthcare workers, and you're going to have to try to recognize what those are and try to work within that framework. Poor communication between parents and us. We don't always explain things correctly. They don't always call us when something's going wrong, all sorts of issues. But communication is often a big barrier. And then family functioning and support. If a family situation is stressful, chaotic, if people are struggling to put food on the table, keep a job, then, and parents are working at nights or double shifts, sometimes getting those medications into children becomes very difficult. There's not necessarily someone to supervise, that parent may not have adequate support, and we have to think about those things, ask about those things, and try to work within that framework and offer any support that we can. Then there's medication issues. Difficulties with using inhalers, not liking to use a spacer, having problems with technique, and then it's not working, so we're not going to use it. Complicated regimens. We make the mistake sometimes, if someone is poorly controlled, that we just add more medications. The more complicated the regimen, the less likely they are to be adherent to it. Adding more medications is not always, and I would say actually is rarely, the right answer. fears about or actual side effects. People are very scared of steroids. Explaining to them what they should expect or can expect with steroids is important. The cost of medicines. Some insurance plans make you pay full price for medicines until you reach a certain deductible. Each of these inhalers is close to $200 plus. These are not cheap medicines. Cost is a huge issue. Distance to the pharmacies or trouble with transportation getting to clinic, just trouble getting to where they need to get the meds or get the care that they need. And there are resources for that through Medicaid and perhaps other organizations, but you need to be aware of what those are in your community. And again, ask about those problems. People are not always forthcoming about problems with finances or transportation. They don't always recognize that you can help, and sometimes it's embarrassing to talk about, or they just don't want to bring it up, or they don't think it's any of your business. But try to address those issues. Often people forget. Life happens, especially teenagers. They're so easily distracted. All it takes is one text for them to go forget to do their medicine. It can be that not that they're not wanting to take their medicine, but that they're just forgetting it. And then there's children who resist treatment, and parents do not like to fight with their children. Having a battle with your child every day, twice a day, about a medication where you're not seeing an immediate effect, many people will opt out of that battle. And that is often the case in these little kids, like the case I presented, where they're using a nebulized inhaled corticosteroid. Nebulizer treatments are great, but they take 15 to 20 minutes twice a day. And in an active toddler who does not want to sit still that long, you may be asking the parent to do something that requires much more energy, time, and fight and battle than they want to deal with on a daily basis. So those are things to take into consideration. So how do we improve adherence? Again, when you talk to them, normalize it. It is not uncommon, nor is it bad if you are forgetting or not taking your medicines. There's some very valid reasons for those things. We are partners with our patients. We work together to find the best medication strategy for them. It's not the same for every patient. There's not one medicine that is appropriate for everyone. And even if I think a certain medicine might be a better medical answer, if that is not a feasible thing in your household, then that is not the answer for your child. So don't scold. Talk to them, explain to them that you appreciate them being honest about missing the medicines, that you understand that that happens and that's normal, and that you want to think with them and partner with them and kind of develop some strategies to keep that from happening. How are we going to work on this together? And please keep telling me if you're having trouble getting the medicine, because it is my job to find a strategy or a regimen that works for you. Engage your families. You can use motivational interviewing to get at some of what the barriers are, education, co-production, and then give them choices. If there are choices, teenagers love choices. Give them choices. Do you want to do a combination medicine twice a day, or would you rather do something, 2 medicines once a day? Do you want to use a spacer or not use a spacer? Providing choices, especially to teenagers, gets them a little more vested in their care. Ask about financial obstacles. There are coupons, there are patient assistance programs, there is help out there. If patients are not on Medicaid and they're eligible, then, connect them with the right people to do that. But ask, again, people don't always volunteer this information. When people have beliefs that are erroneous, misconceptions, or expectations are not realistic for their asthma, provide that education. Explain what asthma is, how these medicines work, what the side effects are, what the goals of treatment are. Many parents think the goal of treatment is to keep them out of the emergency room or the hospital. They are not expecting, and they're very pleased when I tell them, your child shouldn't be coughing at night, should be able to exercise. They're very happy about that. It has not occurred to them that I can actually help them take care of that. So go over the goals. Tell them what you expect. And that does two things. It kind of lets them, not only do they know what to expect, but they know what to look for. So when you bring them back and you ask them those questions, they've kind of already been looking at those things, trying to think about them so they can provide you with better answers. Ask them what they know about their asthma. Don't just teach. If you've done the teaching before, get them to tell you what they know. Ask about their concerns. Again, many believe their children shouldn't be outside. I don't know how many kids get kept inside during the spring season. We're going to avoid all these triggers. Well, that makes sense to a certain degree, but these are children and they need to have normal lives. So maybe getting them on the right medication will allow them to enjoy the outdoors and still not have attacks. Many believe that they will outgrow their asthma. Not everybody outgrows their asthma. And there's no crystal ball, but that is often one of the first questions we're asked. When will they outgrow their asthma? And when is that going to happen? Well, there's no telling, but educate them about that. Explain what factors lead to a persistence of asthma beyond childhood. And then address the fear of steroids. Be aware of and try to work with a family's cultural influences, their health beliefs, their family influences, their support structure. I've had parents who cannot get a medicine into a child twice a day because they're not home. And there may be someone who's poking in and looking at the child, but they're not really someone they trust or they can rely on to make sure that child is getting their medicine. In those situations, once-a-day dosing may be preferable to twice-a-day dosing. So pick the medicines that can be given once a day. Children with parents who are divorced, what happens in one home is not what happens in the other home. There are parents that have problems with substance abuse. There's just family chaos and stress. Be aware of those factors. Sometimes the answer may be to get DHR involved. Hopefully not often. Sometimes it's just kind of, again, troubleshooting with the parents on how we can find something that will work for you. But it's important to not make parents feel guilty or reprimand them for not doing something. They're often trying their very best in very stressful, chaotic situations. Our third case is a 15-year-old African-American female with severe persistent asthma. She's on a high-dose combination inhaled steroid and long-acting beta agonist. She coughs 2 or 3 nights a week. She's very athletic, but she's having a lot of trouble with exercise lately. She's unable to finish a practice or a game without having to stop and take her albuterol because she develops shortness of breath and cough and chest tightness. She's not pre-treating her exercise. She denies any symptoms of comorbidities, and her lung function is 70%, but reverses to 90% with bronchodilator. So a couple of things on this slide. Regardless of anything else that is going on that is leading to poor control, pre-treating exercise, if you're having a lot of exercise symptoms, is important. And we will often pre-treat with 2 to 4 puffs depending on the age of the child. But that alone could help. So that's one strategy. An FEV1 of 70% is in the mild small airway obstruction range, but that it reverses to 90% in and of itself tells you that asthma is not well controlled. A bronchodilator response in a patient that's not on a controller is diagnostic of asthma. once a patient is on a good controller, if they still have, if they still have a bronchodilator response, you either have a patient who's having an exacerbation, is on the wrong medicine and needs more medicine, or is being non-adherent or has poor technique. There's a problem there, because truly, if the asthma is well controlled, that bronchodilator response should not be there anymore. So those practices that have access to spirometry, it's a great tool. One more piece of information that can kind of help guide what you're going to do. So this child has uncontrolled asthma. And again, we're going to look at inhaler technique, adherence, and inadequate treatment. She's already on a high-dose steroid and LABA combination. So potentially she's getting inadequate treatment, but not as likely. So the two things we would really focus on first were inhaler technique and adherence. And in most of our teenagers, the issue is more of an adherence issue. And adolescents are a special group. They're very concerned with being independent and fitting in, and they have greater risk-taking behaviors to begin with. They're very focused on the short-term outcomes and not long-term outcomes. It's not that they don't understand what you're explaining to them. They can. And logically, they can even tell you that that makes sense. But you are immortal when you're a teenager. And so they somehow will reason with themselves that that doesn't apply to them or that's not going to happen to them. They're much more interested in the short term. This is a time when mortality begins to rise in asthma. And in fact, between 15 and 34, asthma mortality rate doubles compared to younger children. So when working with adolescents, work directly with the adolescent. The parent is in the room. The parent surely will offer some information, but direct your questions at the adolescent. Talk to the adolescent. Talk to that patient. If a parent is answering too many of the questions, ask the parent or tell the parent that you would like to hear from that child. It's a good time to start transitioning their care anyway. Educate that patient about their disease. Their parents have gotten all the education, but they haven't necessarily been listening all this time. So re-educate. It's a good time. Encourage them to own their disease. This is your asthma. What you do or don't do affects you and you primarily. And if you want to feel better, you need to take some responsibility, some ownership of your care. Give them choices. Review strategies. If people are forgetting, I often go over how to remember. If there's something you do, if you have a twice-a-day medicine, there's something you do every day, twice a day, that's already a habit, try to tie it with that habit. If you're great at brushing your teeth twice a day, fit it with your toothbrush. Fortunately, not many children are good at brushing their teeth twice a day. But, if you eat breakfast and dinner every day at the kitchen table, put it on the kitchen table. Set an alarm on your phone. They all have phones. Tie it to something that they already do, an established routine. Because the best way to be adherent to any medication is to make it part of a routine. Simplify. Look hard at the medications they're on. Do they need all of them? Get rid of the ones they don't need. The easier you make this, going to once a day versus twice a day, to no spacer versus spacer, the simpler you can make this regimen, the more likely they will comply or they will adhere to what you're asking them to do. And make sure that they know there are always consequences to their actions. They're old enough to be, aware of that reality. If you don't do this, these are your potential consequences. You will end up in the emergency room, or you can end up in the hospital. Or if they're bad enough and they're at high risk, we talk about ICU or even asthma deaths in kids who we are really worried about. But they should be aware of the consequences of not taking their medications. But again, partner with the patient and family, really listen. Really listen to what they're telling you about why things are not happening when they're not happening. Respond to their concerns, even if you don't think it's anything all that important or you don't understand why they're concerned about it. They're worried. You need to address that. You need to address that to their satisfaction. Educate, and then personalize. The best therapy for each child is the one they're going to take, not necessarily your first choice. So in summary, asthma is serious. It's potentially life-threatening disease that affects millions. Can be controlled with appropriate medical management and avoiding risk factors when possible. Attaining asthma control is important because good control correlates with better quality of life, a reduction in the healthcare use, and reduction in mortality. Good asthma management requires us to provide education and training, to communicate well with our patients and their families, and to tailor our therapies to each patient. A lot of the information and studies I pulled are from these references that you will be able to find later with a slide set. And I'll take any questions.
Okay. Thank you, Dr. Lowell. If our audience members have any questions that they would like to email in or call in, we do have a few minutes. Do we have any questions coming in on the email?
No questions at this time.
Okay. We do have some audience questions that I will read here. At what age should a child begin giving their own medication, and how can a parent, do you have any advice for a parent on how to teach their child to give their own medication?
Children should be encouraged to be involved in giving their own medications from a very young age. Children want to. They want to push the puffer down. They want to hold their spacers. It's okay, and you should encourage them to do those things. They will still need supervision. You will still need to ensure that they're getting their medicine. As they get older and they can do the technique on their own, then let them, but watch them, supervise them. As they become adolescents, we want to give them a little more independence and a little more freedom, and certainly that's wise. But you still kind of, even if it's a little more from afar, supervise their medication and that they're taking their medication. Again, I have children with asthma. My son could be on his way to take his inhaler and will get a text, and there goes the inhaler. It happens. They are just easily distractible. They're not necessarily trying to avoid doing things. There's just a lot going on, and this is not a priority. So it is still our job as parents to supervise. But as soon as they are able to administer their own medicines, they should, just with supervision.
Okay, thank you.
Mm-hmm.
I have a question. Given the family history of asthma, do you find that most adults feel that spacers are just for children, and would you recommend addressing medication technique throughout the household just from a modeling standpoint, just to ensure adherence to spacers?
Right.
That's a great question.
Unfortunately, that is a wide-held belief that spacers are just for children. But in truth, when you actuate your puffer, you have to be in mid-inhalation for that medicine to get your lungs. If your timing is off even a little, that medicine is going to end up at the back of your throat, where you will experience potentially the side effects of the medicine, but very little benefit of the medicine. That level of coordination is difficult for adults, not just children. So I firmly believe that even adults should be using spacers with their puffers. I explained to parents why the puffer will not work without the spacer. The spacer holds the medicine. You no longer have to coordinate. You breathe in when you're ready, and more of that medicine gets into your lungs. So it's not coming out as hard and fast, and you're not having to time it just right. at best, with most of our inhaled corticosteroids, 12% of that medicine gets into your lungs. If your technique is off, the percentage of medicine getting into your lungs is so low that it may not help you at all. So, yes, we do tell parents that we expect everyone, even adults, to use spacers. When children stop using their spacers because parents think they're old enough, we kind of re-educate them about that. But I'm a firm believer that unless you're using a dry powder, everyone should use a spacer regardless of age.
Okay. Thank you. And I see we do have a phone call question coming in. We have a phone call from Gadsden, Alabama. Hello, you're on the line.
Yes, I am.
Go ahead with your question.
Yes, I am. Hi, my name is Hope.
Hi, Hope.
Okay, hi, I'm calling from Gadsden, and my question is, all right, what is your preference between using a nebulizer and just the inhaler? Because some patients come in and the parents will prefer nebulizers
Right.
instead of the inhaler.
It depends on which medicine we're talking about. In general, my theory is whatever is easiest is likely to get done. I will say this, spacers, or puffers with spacers, your technique has to be on. If your technique is off, you will not get the medicine. So in an asthmatic who's having an acute exacerbation and has a spacer with a mouthpiece and cannot hold their breath for 10 seconds without coughing, especially the 4-6 times in a row that we've asked them to do, then a nebulizer is preferred. If your technique is bad, a nebulizer is preferred. If you can do the technique correctly, the puffers are quicker and easier and portable. There are some children, though, who really just cannot accept a spacer. A lot of my children that I see that are autistic, parents really have a much easier time with a nebulizer. So if a parent is very clearly telling you that they reject the mask and the spacer, or they just can't seem to get it, assess technique in your office, and if it's true that they just really don't have it down, the nebulizer is a better choice in terms of both a preventive and a rescue med. In terms of just quick relief, which is going to provide better quick relief, it really depends on how tight they are at that time and whether they can do the technique correctly.
Do you have any questions? Okay. Well, thank you very much. We have used up our hour and then some, and so we will wrap up our broadcast for today. We want to thank Dr. Lowell for sharing her expertise with us and remind our viewers that the slides and handouts are available on the website and that the broadcast is archived on the Department of Public Health website. So thank you all for tuning in and joining us today to learn more about a personalized approach to pediatric asthma management.